Okay, I'm talking a little bit about development of the gut, and then we're gonna go into the more congenital slash embryonic GI pathology. So the gut develops first with herniation of the midgut through the umbilical ring. Actually, before I talk more about this, I just suggest that you watch the video that I've included in the link, and you will have a much better idea of what I'm talking about. But first, midgut herniates through the umbilical ring. After that happens, it will return back to the abdominal cavity, and it's going to rotate 270 degrees counterclockwise around the superior mesenteric artery. And that's how you get development. Okay, so that's a terrible explanation. Please just watch the video, you understand what I'm talking about. Now, what happens when things go wrong? We have ventral wall defects. That's our first one. There's two of them. First one is gastroschisis. The problem here is extrusion of your abdominal contents through a defect in the abdominal wall. So there is a defect in the abdominal wall. So now your small bowel intestines are going to be able to come out. As you can see from the picture, the bowel is not covered by anything. And there's no associations with this disease. If you look at omphalocele, this is a persistent herniation of the bowel into the umbilical ring due to failure of normal return. What did I just tell you about the embryology? I told you that normally the midgut will herniate through the umbilical ring, and then eventually, a few weeks later, it's going to come back. In this case, it doesn't come back, and it just stays out there in the umbilical ring, and it looks like this. And the key here is that it's covered by a peritoneal dome. That's the key difference. So this one has a dome, peritoneal dome. This one is not covered at all. So I think of this as dome phalocele, and that's how I remember. This is a very important difference because you're going to get tested on this a lot. Omphalocele has the dome, it's the dome phalocele. Gastroschisis does not. Another difference here is that omphalocele is associated with a lot of different other disorders. So you see omphaloceles with different trisomies, trisomy 13 or 18. You can see it with Beckwith-Weiterman syndrome. Which one was that? And that was the one with Wilms tumor, and then the hemihypertrophy and the big tongue. You can also see this with other structural abnormalities. So that's it for ventral wall defects. Do know that you do get tested on this pretty often. So congenital umbilical hernia. This is due to failure of the umbilical ring to close after the midgut does return to the abdominal cavity. So midgut does return, but the umbilical ring remains open, and so now your bowel can still go back out through this umbilical ring. And that's what happens. You can see here that there's a little protrusion here. That's due to the intestine pushing out. Now note that this defect usually will close spontaneously. Okay, so you can just let it be for a few years, and it usually closes. Next is tracheoesophageal abnormalities. So these are problems, as you can tell from the name, either with the trachea or the esophagus or both. Now the first one is esophageal atresia. Atresia means there's failure of development. So you can see here, this is the trachea, and this is the esophagus. You see there's a closed thing. It's not connected at all with the rest of the esophagus. That's atresia. Okay, so now the esophagus has a blind ending. The next one is the tracheoesophageal fistula. So fistula is a connection between two things, and in this case it's this connection between the trachea and the esophagus, as you can see here. Next is finally you can actually have both. You can have both atresia, as you can see here, there's atresia of the esophagus, and a connection, abnormal connection between the esophagus and the trachea. So that's esophageal atresia with tracheoesophageal fistula. Now clinical features here. One thing to think about is what's the amniotic fluid going to be like? Well, normally the baby will swallow amniotic fluid and decrease the levels, but in this case, baby can't really swallow, as you can see, because amniotic fluid comes here and it comes right back. Amniotic fluid comes here, it comes right back. So they're going to have polyhydramnios. So there's going to be excess amniotic fluid in the mother's womb. And then the other thing that the baby can have is drooling, choking, and vomiting. As obviously, as you can see, whenever they take some food in or some liquid goes in, comes back out. They're choking, they're going to be vomiting. Oh yeah, or maybe there's a fistula. The food goes here and goes into the lungs. They're going to be coughing, choking. So not good. And then if there's esophageal atresia present, then you can diagnose this let's clear this out. If you stick a tube down their mouth, down their esophagus, normally the tube can go all the way through into the stomach. But if there's esophageal atresia, it does not, it gets stuck. And that's how you know that there's esophageal atresia present. Next is duodenal atresia. So same thing, except for this happens in the duodenum. As you can see here in the bottom left picture, there's a blind ending of the duodenum. It does not connect to the rest of the duodenum. And this is due to a failure of recanalization of the duodenum during development. Failure of recanalization leads to duodenal atresia. Clinical features here. There's a double bubble sign on the x-ray. What does that mean? There's a bubble here, and there's a bubble here. And where does this bubble from? Bubble comes from the air. You're seeing air in the GI tract, which comes through the mouth, so that's normal. But the problem is that the air collects here because it's the blind ending. So this is the air. This is the small air pocket. There's that big air pocket that I showed you. That's the stomach. This is the duodenum. You can see two bubbles because the rest of it's going to be closed off. So there's no air going into the rest of the GI tract. Now the question is there's going to be emesis for sure, because if food can't keep going, then it's going to go back out, and it's going to go back out through the mouth. So the question is it going to be bilious or non-bilious? Bilious means there's bowel inside the vomit, and that means that it's like a green color. And the reason it would have bile in it, well, bile normally comes, remember, from the gallbladder and the liver, and it goes into the second part of the duodenum. It goes to the pancreas in the second part of the duodenum. So where your atresia is will determine whether you have bilious or non-bilious emesis. In this case, if the bile is going here and the vomit's coming from here, then it'll be non-bilious. However, in duodenal atresia, maybe you have atresia that's more up here. That's more before or after, I'd say, after the bile ducts. So bile comes here, and then you vomit, and it's going to be bilious vomit, okay? So it can be either in duodenal atresia. It just depends on where the atresia is. Next is that the associations of this disease. You can see this disease with Down syndrome, okay? Duodenal atresia, often seen with Down syndrome. Next we have jejunal or ilioatresia. And this one actually has a different cause. This one is more due to a vascular occlusion leading to ischemia. So you have ischemia, and then you have atresia of the intestinal lumen. And what happens is you actually get an apple peel-like appearance of the intestine. So it looks like an apple peel, as you can see on the right. Now the question here is, will there be bilious or non-bilious emesis? I explained to you that if the obstruction, if the atresia is after where the bile ducts enter, then it's going to be bilious, okay? And in this case, the obstruction is after. So let's see, bile ducts enter here, obstructions further down here. So you do have bilious emesis because bile comes here, and then it can't go down the intestine, so it's going to go back up into the mouth. So you have bilious emesis, and you also see abdominal distension. The more distal atresia, the more likely abdominal distension occurs, okay? So that's why you see this more in jejunal/ilioatresia than in duodenal atresia. Finally, this one is associated with gastroschisis. You could think of it because the etiology here is vascular occlusion, and then what was the problem with gastroschisis? When gastroschisis was a defect in the abdominal wall, and this hypothesized also that may also be developing, resulting from vascular defects as well. So poor vascular supply to the abdominal wall leads to defect in the abdominal wall, and then it could also lead to ischemia and atresia of the intestinal lumen. So that's how you can get gastroschisis and this jejunal/ilioatresia. Alright, so next thing is hypertrophic pyloric stenosis. Look at the name, you know a lot, okay? It's problem with the pylorus, there's stenosis, which means it's closed off, and it's because it's hypertrophic, so it's grown too much. It's hypertrophy of the pyloric muscle of the stomach. Pyloric muscle is here, okay, right at the exit of the stomach. It's grown too big, food can't get out. So what's going to happen? Food can't get out, so where's it going to go? If you can't go into the small intestine, it's going to go backwards, up into the stomach, up into the mouth, and you're going to get vomiting. Now, I ask you again, is it going to be non-bilious or bilious vomiting? Well, bile is here, bile is coming here, and the vomit is coming around here, so it's going to be non-bilious vomiting. Do you think, the other thing you feel on exam is you can actually feel this hypertrophy of the pyloric muscle, and it feels like an olive-shaped mass, okay? Olive-shaped mass is key word for hypertrophic pyloric stenosis. It's such a super easy, one of those words that you already know the answer. And the other thing you can see with this disease is you can see visible peristaltic waves over the abdomen, because you have this obstruction, you're peristalsing against it, but nothing's going, so you're peristalsing stronger and stronger, and so that's how you see these peristaltic waves over the abdomen. Treatment here, you just cut the muscle, you incise the thickened pyloric muscle. Now it's smaller, there's more space for food to go and go into the small intestine. So again, just know a lot, you can tell a lot from the name. You already know where the obstruction is, so you know it's non-bilious vomiting. Makes sense, palpable olive-shaped mass. Now I'm going to talk about the Vitelline duct. The Vitelline duct connects the midgut lumen with the yolk sac at the umbilicus early in embryonic life. So that's how the baby is getting nutrients very early on, from the yolk sac to the umbilicus. Normally this will obliterate, okay? Normally this obliterates so that the placenta can take over to give nutrients to the baby. But if this Vitelline duct fails to obliterate, there's a spectrum of abnormalities that can occur. First one is just called a persistent Vitelline duct, so you can see what this is. This is the umbilicus right here. This is the gut, the small intestine, and there's a connection between the two, and that is a persistent Vitelline duct. So the most common thing you'll see if this is present is in a newborn is that there's like little poop, like we call it meconium in a little baby. But poop normally goes down this way, but it can also leave this way. So you can actually see meconium discharge from the umbilicus if this is present. You know it's a persistent Vitelline duct. The next one I'm talking about is a mecodiverticulum. We're going to talk more about this later. This one you see a lot. Mecodiverticulum occurs when part of the Vitelline duct closes and one part stays open. And the part that stays open is at the ileum. Okay, this is the ileum. This is partly open, partly non-closed Vitelline duct, which we call the mecodiverticulum. And this side is the side that closed. Okay, Vitelline sinus is the opposite. Again, only one part closes, one part stays open, but the open part is at the umbilicus, the closed part is at the ileum. So this is called the Vitelline sinus. Finally, we have a Vitelline cyst. So that happens when the two ends close off, one end closed off, two ends closed off, but the middle remains open. Now you have a cystic-like structure in between the two. So Vitelline duct, nothing closes at all. Meco and Vitelline sinus, part of it closes, and then the Vitelline cyst, the middle stays open. So more about mecodiverticulum, you're going to get tested on this a lot. Again, this is from partial closure of the Vitelline duct, and the key part here is that this diverticulum often contains ectopic gastric mucosa that secretes gastric acid. We call it ectopic because there's gastric mucosa where there shouldn't be, because this is in the ileum and usually it should be in the stomach. Now it's going to be secreting acid, and this acid is very caustic. It basically causes damage to the mucosa, the surrounding mucosa. Okay, it's going to cause ulceration and it's going to cause bleeding. Alright, I also want to note, actually, before I go into that this was a true diverticulum. Remember I talked about that? I talked about true and false diverticula. And what was a true diverticulum? Remember that a true diverticulum is an outpushing that contains all the layers of the intestinal wall. So mucosa, submucosa, muscularis, externa, and then the serosa. A false diverticulum, remember, only had outpushing of the mucosa and the submucosa. Remember that the muscularis externa did not outpunch in a false diverticulum. So how this presents is, remember I said that it's going to be secreting gastric acid, it's going to cause ulceration and bleeding. So what you're going to see is bleeding the rectum, okay? The other things you can see is volvulus, intussusception, and right lower quadrant pain. Volvulus is where your intestines get all wound up together and they obstruct each other. Intussusception, I'm going to talk more about that later, but it's telescoping of one part of the intestine into the other, and that can cause a lot of pain. And finally, it's right lower quadrant pain because there's a problem in the ileum. So that's the right lower quadrant. And the thing here is that this can mimic appendicitis. What do we say about appendicitis? Remember, it's at the right lower quadrant at the McBurney's point. Okay, there's also a rule of twos that you should know about mecodiverticulums. 2% of the population, 2 feet from the ileocecal valve, 2 inches in length, and 2% of patients are symptomatic. Males are two times as likely to be affected. So only 2% of patients actually experience these symptoms. Okay. The way you diagnose this is also testable. So the test for this is the 99 mmTC per tectinate scan. What it does is it's going to identify any ectopic gastric epithelium. So if you see ectopic gastric epithelium, then you can diagnose macrodiverticulum. And what was the test name? 99 TC pertectinate scan. Okay, now we're going to talk about pancreatic and spleen embryology. So, the foregut is where the pancreas and the spleen come from. Remember, all the extra organs that are not part of the intestines and the stomach and the esophagus are all part of the foregut. Foregut gives rise to both the dorsal and the ventral pancreatic buds. So the dorsal is towards the back, ventral is towards the front. Okay. Now, the dorsal bud is going to become, the dorsal bud is this yellow one. As you can see, this is the final product. Okay. Dorsal bud is going to become tail. This is the very tail, the body, and a lot of the head of the pancreas. Okay. And then there's also some of the pancreatic ducts that's going to become. A ventral bud, which is the red, is going to be, as you can see, part of the head. And then there's going to be something called the oxynate process. That's also going to be coming from the ventral process. And then the proximal part of the main pancreatic duct that you see here is also from the ventral pancreatic duct. Okay, so dorsal bud, ventral bud. Dorsal bud makes all this back part of it, from the tail to all the way to part of the head. And then the ventral ventral bud makes up the head, part of the head, oxynate process, and the proximal pancreatic duct. So normally how these two come together is that the ventral pancreatic bud, as you can see here, it's going to rotate. It's going to rotate behind the duodenum. I try to draw it so that you can see it going behind the duodenum. It's going to come all the way here, and then it's going to fuse with the dorsal pancreatic bud. Okay, so that is how it normally develops. Now, this can actually go wrong though. This can go wrong. And what happens when this goes wrong? Well, one thing that can happen is you can have failure of fusion. Okay, so it rotates, but it doesn't fuse. So now you can see we have our ventral pancreatic bud and our dorsal pancreatic bud, and they have not fused. Usually this is asymptomatic, but sometimes you can have chronic abdominal pain or pancreatitis. So this is called pancreatic divisum. Pancreatic divisum from failure of fusion of the dorsal and ventral pancreatic buds. The other thing that can go wrong is something called annular pancreas. So this is due to abnormal rotation of the ventral bud. Pancreatic divisum, failure of fusion. This one, abnormal rotation. So what happens is that instead of doing a nice rotation, it can actually just rotate and get stuck around the duodenum here. And it's going to surround the second part of the duodenum. So this is usually asymptomatic, but as you can see here, if it's surrounded too tightly, it can cause compression of the duodenum, and then compression means obstruction. And then if you have obstruction, the presentation of this will be with vomiting. So you can get obstruction of the duodenum from annular pancreas. Alright, so next is intussusception, which I mentioned a little bit before. This is telescoping of the segment of bowel into an adjacent segment. Okay, as you can see here, this is part of the bowel, and it's telescoped into the part next to it. It's like pushed, it got pushed in. It's like just like when a telescope collapses, that's how it looks like. And this is going to lead to impaired venous return from the intussuscepted section. So we have all these blood vessels here. Okay, but these are all compressed, as you can see. They're all getting pushed in, and there's not much venous return. So now you're going to get ischemia and necrosis of this bowel wall. It's going to die off, okay? It's going to die because there's compression from this telescoping. Note that this problem normally happens at the ileocolic junction. It's between the ileum and then the large bowel, ileocolic junction. You often see this in young children. Often there's no structural cause, it just happens. If you see this in an older patient, there's usually something called a lead point. It's something that basically causes traction, it acts like a hook. Okay, that's like a lead point that causes it to get stuck in here, and so this bowel that went in can't come out. So that's something like an intestinal tumor, or sometimes you can see this in children, like a macrodiverticulum can cause intussusception, which we mentioned before in the macrodiverticulum lecture. So the presentation here is going to be severe colicky abdominal pain. The reason why it's colicky is because your abdomen is going to peristalse, and when peristalsis, as you can see here, that's not going to be fun here. So it's going to be colicky abdominal pain. And then you can also see there's going to be some obstruction here, and it's just the pain, it's all going to cause nausea and vomiting. And then you can see current jelly stools. I just told you that there's going to be ischemia and necrosis because of compression of the venous drainage of this small bowel. So when this ischemia and necrosis, what you're going to get is you're going to get bleeding. And then there's mucus in this intestine, because remember, there's mucus to help us lubricate the food, prevent acid damage. So mucus is going to give it that jelly look. Current is like the red current is going to come from the bleeding. Okay, so intussusception, telescoping of the small bowel into adjacent segment, most commonly ileocolic junction. Okay, malrotation. Malrotation happens due to abnormality in mid-gut rotation. Remember I told you in development of our gut, you get herniation in the umbilical ring. What happens next? Then eventually it comes back into the abdominal cavity, and then it rotates 270 degrees. In malrotation, this shows you what happens when that goes wrong. Okay, what's going to happen is your small bowel ends up here. This is the small bowel, and this is your large bowel, and you're going to get these formation of fibrous Ladd bands. It's going to be connecting the large bowel to the side wall. Okay, there's a couple complications that can occur from this. First, you can have intestinal obstruction from compression by Ladd bands. You can see these are fibrous bands. They can compress parts of your bowel and cause obstruction. The other thing that can happen is you can get something called a volvulus. It can be due to a twisting of the intestine around the superior mesenteric artery. And when you twist, and you're going to disrupt the blood supply, and that's not going to be fun. And I'm going to talk about volvulus right now. But again, malrotation leads to these complications of obstruction from Ladd bands or volvulus due to twisting. It's just more susceptible to twisting when it's in this malrotated position. So volvulus, I just told you, twisting of bowel around its mesentery. Mesentery is the tissue surrounding it. And then what's going to happen is you're going to get this twisting, and you can see poop can't come out of here. It's just all stuck up. So poop, there's obstruction, and then you're also going to get disruption of the blood supply. So the other thing to note is that midgut volvulus is usually seen in children, and you can get a sigmoid volvulus, which is by the distal colon in older adults. Elderly patients is the word I used here. And it's going to look like a coffee bean. The coffee bean sign, as you can see here, is associated with the sigmoid volvulus in older patients. It looks just like a coffee bean. Alright, next is Hirschsprung disease. Hirschsprung disease is a congenital megacolon, so superdilation of the colon, and it results from a missing Auerbach and Meissner nerve plexus in the distal segment of the colon. So I've drawn out the nerve plexus here in the yellow. So you see nerve plexus here. There's nerve present all the way up till the distal segment, and now you see that there is no nerve plexus here. And what was the point of the nerve plexus? Remember, nerve plexus helps in GI motility. So if you don't have nerve plexus, and this results from failure of neurocrest migration, there's going to be no motility here, and there's going to be no movement of poop. So if the poop can't move, it's going to get stuck up here. There's all this poop here, okay? So that's what's going to happen. It's going to become obstructed, and then this part's going to just fill up with poop, and it's going to get dilated and it's going to be full of feces. So clinical presentation here is going to be obstructive symptoms. There's basically a big fat obstruction here due to lack of the nerves in the distal part of the colon. And obstructive symptoms include some things like bilious emesis, abdominal distension, meconium ileus. Remember, this is congenital. Babies born with this. So their meconium ileus is failure to pass their first meconium, which is like their first poop. So because they can't propel here, their first poop's not going to come out either. So they get meconium ileus. And then there's also chronic constipation. Now to diagnose this, one way you can do this is with the squirt sign. And what is the squirt sign? Squirt sign is an explosive expulsion of feces on digital rectal exam. Okay, you put a finger up here, and that's gonna stimulate the colon, the rectum enough to cause all this feces that's been built up to be expelled. And it's gonna be like a squirt, a big fat squirt, and that's a squirt sign that you see in Hirschsprung disease. Okay, the other thing you can do, let me clear this out, is you could do a biopsy of this rectal tissue. If you do that, what would you expect to see? You would see an absence of ganglionic cells, absence of the nerve cells, and that's diagnostic for Hirschsprung disease, okay? Alright, the way you treat this is, all you have to do is resect a ganglionic segment. You cut this part out, now you're fine. Now the rest of your colon has a nerve plexus, and now you can poop again. Okay, so Hirschsprung disease, congenital megacolon from missing nerve plexus presenting with obstructive symptoms. Okay, and what were the obstructive symptoms again? I just want to test you. Remember, bilious emesis, abdominal distension, meconium ileus, chronic constipation. You don't have to memorize this, just recognize that those are all obstruction problems. Okay, necrotizing enterocolitis. Look at the name. It's a necrotizing, it's inflammation. Entero means part of the GI system. Okay, necrotizing inflammation of the intestine, and it's seen in preterm infants. The reason it's seen in preterm infants is these infants have immaturity of the GI and the immune system. So, preterm infants with immaturity of GI and the immune system. So what happens, how this occurs is that feeding, actually let me just explain that. Feeding is going to introduce bacteria into the gut. And this bacteria is not properly cleared because I just told you that the immune system sucks right now because this baby's preterm and hasn't developed a good immune system. And their GI system was weak, so there's a poor mucosal barrier. So bacteria is going to invade the bowel wall. Bacteria is going to invade the bowel wall. It's going to cause inflammation and ischemic necrosis. The other thing it's going to do, it's going to produce gas inside the intestinal wall. It's going to present something called pneumatosis intestinalis. Okay, so let me say this again. Poor immune system lets bacteria survive. Poor GI development means poor mucosal barrier. Bacteria enters the GI wall, causes inflammation, ischemic necrosis, produces gas inside the intestinal wall. What was the name for that? It's called pneumatosis intestinalis. Now you have messed up the GI wall, so you can have intestinal perforation. So this is a severe problem. So that's necrotizing enterocolitis. So that's it for our summary of all the congenital GI abnormalities. These are all pretty testable, so make sure you review them.